Welcome to the Grand Rounds for the Underground podcast. The views and opinions of the speakers are their own and do not represent anyone else's. Let's get to the podcast.
Like I said, the variable of combat was not taken into account because you may have gotten blown up, or they may need another gun in the fight. So you went ahead and proceeded to help, maintain the initiative of the assault or the gunfight. And then that patient was evacuated without you being able to put another set of hands on them to reassess or do anything. But and this is where in peacetime, and from that view where you're only looking at it from the medicine aspect, you don't take into account the variables of combat. And that is where I think that this tourniquet debate, even in some of those, because I've been in some of those debates, they are not talking about that. And when you bring it up, it's very dismissed they get dismissive of those situations. And why? Because the majority of them don't have that experience.
Yeah.
And don't understand that speed is security. And sometimes you need to stop what you're doing and move the patient. And you may not get a chance to get back to that patient because of an evacuation or because of A, B, C, or D. And right now, we're making decisions about point of injury. And one of the things we've lacked for years is documentation, accurate documentation. Yes. And I know Tatrick for many years has looked at verbal devices, and they have not been able to make that work out. But we're not too far away. When I say that, I've looked at industry, and industry has some availability to do this. And I'm not talking with the stuff that you see on your phone with Siri that constantly gets your voice wrong. There are better things out there. Like when you think about Siri or the one for Android and blah, blah, those are the bare minimum. That's like, if you went to a flea market and got that technology. There's other technologies that are out there that are more expensive that actually have you read a paragraph. So that way the program can identify the speech impediments that we all have that a speech pathologist could probably tell you if you ever got, and they integrate that. So that way they understand. And then the other problem too is that whenever we start talking to Siri about medical terms, like say we said like epicondylitis, it is not going to put epicondylitis on there. You have to have the AI within that realm of verbiage and knowledge. There's some other factors, but in the next, I definitely see within the next 5 to 10 years, us being able to advance that point. However, that's going to be another power draw from some type of radio, or a device that we're going to have to carry amongst everything else that we've got to carry. And
well, Tatrick's working on a AI that will fill out your casualty card for you just by seeing through the camera and whatnot, what your hands are doing, what's going on with the patient, where the wounds are, and they're developing that, certain actions, from what I hear.
And as a matter of fact, it's kind of funny because DARPA has a program, and I don't know if they're working with Tatrick on it as well, but that they're doing something similar to that. And so hopefully that'll come out. But here we are making decisions about point of injury care, but the majority of the panelists and the majority of the committees that are making these decisions are not a 50-50 split between medics that have firsthand experience versus theoretical retrospective data that has been acquired. You can write, just like we've talked about, you can write the perfect plan on paper, but in practice, does it work? So some evidence is the conclusions that can be drawn can be misleading. And I tell people this all the time, as much, I've experienced a lot of things, but other people have traveled in their career and they experience other things. So points of view definitely matter. And so none should be really dismissed, but we should, try to take as many as we can. And right now at point of injury, we're going to have to look at some empirical data versus, evidence-based data, because it doesn't fit neatly into the typical, PICO format and to the proper, types of studies that are available out there. And this brings me to another little point. When we look at special operations medicine, learning from our partner forces, and I don't know how many people know this or not, but NATO, or SOFCOM, used to be NSHQ, NATO headquarters, NATO Special Operations Command, but SOFCOM is the new name, for it. There are several courses that they offer throughout the year, and you can actually host a course. They can go and participate. However, we very rarely do. And this is a great time not only to have a cohort of other of our NATO alliance partners together and learn what their capabilities are and understand the limitations that they have in aircraft or they might have in a maritime interdiction.
Even legal aspects from their
Absolutely.
home countries. I mean,
Yeah.
when we were talking at the irregular warfare, medical get-togethers there, often as Americans, we're arrogant in that we think that we have the solution to other people's problems. And listening to people who this is very poignant to, when you're sitting there with the Polish, for instance, Russian invasion, Russia's on their border, and yeah, when you look at some of these other European nations, our Five Eyes allies, their situation is different. They have been thinking about this. They've been planning about this. But then you have some countries that their laws are, I mean, even Ukraine, once they were invaded, it took like 9 months before they were allowed to push blood. Medics were allowed to push blood. That doesn't mean they weren't doing it, but legally they weren't allowed to until like 9 months post invasion. So when we look at planning with those partner forces, we need to listen. We need to understand their perspective and together come up with a way to address those, not dismiss them.
And to your point, we've got so many medics and so many physicians that don't take advantage of those courses to understand. And really, U.S. is kind of far behind on a lot of things. Use of ketamine is one of them, but we all have different points. There's some countries where their physicians are not allowed to carry weapons. And so the availability for them to push them far forward, they become even more of a liability.
Yeah,
because
absolutely.
if the dynamic of the environment changes, they don't have the survival skills and they don't have the availability to actually, take care of themselves. And then one of the things too, that as you try to look at this is from a very high strategic level, how does our equipment interact with others? Can I put somebody in a check or a hospital and have them work the equipment? Can they read the label on a medication from Singapore?
Thanks for tuning into the podcast. We'll see you next time.